the computer. Okay, so today we'll be speaking about the fluid. Now, I'll give you some introduction, component of fluid therapy, how prescribe it, what is the difference of the fluid in newborns, how we replace, and we'll give some scenario at the end. This is the previous hospital that I was the head of an ICU, PICU. It's a Saudi German hospital in Ajman. And so the goal of therapy is to preserve normal volume and preserve normal electrolyte. That's the goal. And we give resuscitate, and then we give maintenance. The resuscitation is usually we give the deficit, and then we give the maintenance, and the maintenance including the ongoing loss. The ongoing loss is of water electrolyte, can be in the urine, in the sweat, in the respiration, in the stool, from the skin, evaporation, and so on. So these are all insensible loss. Insensible loss mean loss that we cannot measure. The patient clinical status and the setting, such as post-operative, preoperative, and others, will affect the hydration status of the patient. And sometimes in some clinical status, it affects the antidiuretic hormone. So when you secrete, when become antihydro over secretion, it causes some volume overload. Now, the component of fluid therapy is fluid and electrolytes, the speed that we give the fluid, or we give also dextrose as a calories, and we consider the sickness level and what type of access, IV access that we have. Now we'll start with the water. Two things that we will discuss: what is the normal physiological need, and how we calculate the fluid or the water giving to the baby. Now, there is hemostatic control of water depend on antidiuretic hormone first, that preserve the water. Second is ability of the kidney to regulate the water loss. And third, how much the human being take. So this mechanism allow variable intake of fluid without affecting the baby. So you can see that each person will take different fluid amount, but there is no difference. There is no side effect. Okay, now it's very important. These are very important slides. The water requirement of IV fluid based on calories. In pediatric, we can go up. We can get more calories with less fluid. However, in neonate, we need more fluid to get the calories. So you can see that in pediatric, you can take 100 ml, and for that, you can consume 100 kilocalorie. However, in 100 ml in newborn babies, you need less than that. So we take from 68 kilocalorie per kg to 100. And that translates to 20 kilocal formula. Okay? So 20 kilocalorie formula, or 1 scoop of milk, or chela scoop, usually give it one level, one number. And the number usually it's 30 ml. But it's not 30 ml, we approximated. It's actually 28 milk. And that's the reason why we give the normal milk, the all normal milk, the companies call it milk type 1 and number 2 and number 3 and whatever, all normal. It's all 20 kilocal formula, or it's 0.68 kilocal per ml. or it's 68 kilocalorie per 100 ml. Now, is this understandable or not? It's very important to understand. So if you don't understand, I repeat. If you didn't understand this. Did you understand this slide?
والله الدكتور إذا ماكو زحمة بس repeat it.
Okay, so in pediatric, we need less fluid to consume calories. And therefore, we can give 100 kilocalorie for 100 ml, or 1 kilocalorie for 1 ml. In neonate, however, the neonate need more fluid for the same calorie. And therefore, the normal calories consumed is about 68 for 100 ml. So you need more fluid to consume same calories. And that's the reason when we do the milk, the standard milk, or what we call it, 20 kilocal formula, the standard formula for newborns and type 1 and type 2, all are 20 kilocal formula. Okay, 20 kilocal formula means 20 kilocalories per 1 scoop. And 1 scoop, usually we dissolve it in 30 ml, رقم واحد. 1 رقم, okay, 1 level in the bottle. It says 30 ml, but it's just approximation. It's usually 28 ml. So if you convert 20 ml, 20 kilocalorie in 30 ml, it will be the same of 68 in 100 ml. Okay? Because if you divide 100 divided by 28, how much it will be? You have a calculator? Divide 100, divide 28. How much you will get?
3.5.
3.5. So divide 68 by 3.5. How much you get?
تقريبا 20.
20.
21.
You get 20, 19, 19.4. So you get 21, 22 kilocal formula. So 20 kilocal formula, it's called F68. F68. That means it has 68 kilocalories in 100 ml, or 0.68 in 1 ml. And it's the same 20 kilocalories in 1 scoop, in 1 level, in 130 ml, or 28. Is that understandable now? Is it clear or not clear yet?
Oh, okay, okay,
Yes?
doctor, it's good.
Yeah. So you can see that pediatric
Yes,
and
yes.
newborn, we never give more than 100 calories for 100 ml. So it's always 1 ml for 1 calorie. In adult, we can give 1.5, 1.6 kilocalorie for 1 ml. In pediatric and newborn, we only maximum we can give. So in a newborn, we rarely give 100, which is hypercaloric formula, or 30 kilocal in 28, or 28 to 28, because this is usually approximate. Okay? And we'll discuss the milk later on, because you need to understand, because I found that many people don't understand the milk here. Okay. What is the normal physiological need of water based on weight? So in first 10 kilogram, the maintenance, the normal need is 100 kilocalorie per kg. In babies more than 10 kg, but less than 20, we need 1,000, which is the first 10, plus 50 for each, 50 kilocal for each weight above 10. So if, let's say, the weight is 12 kilogram, then it's 1,000 plus 100, 110. So if the weight is 15, so it's 1,000 plus 5 extra, because more than 10 is 5. 5 times 50, 250. 250, so it will be 1,250. So if it's, let's say, 17 kilogram, so it's 1,000 plus 7 extra, 7 times 50, 350, and that will be 1,350, and so on. Is that clear or no? First 10 kilo, 100 kilocalorie per kg. Anything above 100, so let's say 12, mean 2 above 10. Let's say 13, mean 3 above 10. Let's say 16, means 6 above 10. So for weight less than 10, it's 100 kg, 100 kilocal per kg. For weight more than 10, but less than 20, it's 1,000, because 100 for each kg, will be 1,000. Anything extra, so if it's 12, 2 kilo extra. If 16, 6 kilo extra. We multiply 6 by 50, because anything extra will take 50 kilocal. Is that clear? Please talk to me.
Yes, it's clear, doctor.
Yes, doctor.
Okay. If it's more than 20, but less than 80, then it's 1,500. Why? Because first 10 is 1,000. Second 10, only 50, so it's 500. So 500 plus 1,000, it's 1,500. And anything above 20, okay, will take only 20 kilocalorie per kg. So let's say if the baby is 25, then it's 1,500, and above 20 is 5. So 5 times 20, that will be 100. Then it will be 1,600. Okay, and so on. If the weight is more than 80 kilogram, then it's 2,700 kilocalories, and then we can adjust. Now remember, this is the start. Now we have to adjust later based on the status of the patient, losing weight, gaining weight, blood gas, urea is high, and so on. We have to adjust. Is that clear?
Yes, it's clear.
Okay. When we replace the fluid, based on calories, we replace the maintenance. So we said, depend on how much calories you need, we'll give you fluid. Okay, but also we have insensible water loss from respiratory tract, from skin, and we have sensible water loss, which is the urine and stool. So we both need to replace it. Okay, now I don't want to go to details of that. It's not very important because I don't want to confuse you. But anyhow, we need to replace this fluid. Okay, now stool usually is negligible amount, and water, urine, we can calculate. And if the baby is on diaper, we weigh the diaper before and after. The difference is the mil. So let's say if the diaper before the patient uses 20 grams or 50 grams, and after he put it on, it become 1,000, then the difference is the urine. So the gram of weight of the diaper after being full in urine is the mil of urine. So let's say if the diaper is 50 grams before we use, and it's become 100, then the urine output on that diaper is 50 mil. Is that clear? Yes? No?
Yes,
Clear.
it's clear.
Okay. Now the dietary solute load. Now remember, we talked about the sensible water loss. When we calculate the loss, we have assumption. So when we calculate based on the following assumption, when we calculate the standard urine loss, first is that normal intake. The solute, the electrolyte that we are taking are normal. Second, the osmolarity of urine are normal. And the antidiuretic hormone is working well. and the concentration ability of the kidney is normal. So these are assumptions. When based on these assumptions, we replace. So if these assumptions change, then the fluid replacement should change. Okay, now it's very important that to remember that premature baby, they don't have reserve. So usually they lost the reserve in premature baby at 6 hours. So before 6 hours, within 6 hours, you start giving them glucose, and you start to have feed as much as possible. And if you cannot give feed, then you need to give TPN. Now remember that being on CPAP, being on ventilator is not contraindication for feeding. And it's not reason to stop feeding. Now, even if you give feeding and there is complication, it's better than the complication of not feeding. Okay? And therefore, a premature baby easily get hypoglycemia because they don't have reserve, and easily get in catabolic stage and start losing weight and start to deteriorate. Now, in premature babies and term babies, we have goals. We have actual and we have goals. Most of premature baby, they lose about 15% of their weight. The goal to allow them to lose only 10%. Baby, they usually lose 10%, but the goal to allow them to only lose 5%. Now, if we gain the birth weight by day 7, so let's say if the birth weight is 3, and on day 7 is 3, we're doing excellent job for feeding and giving nutrition. Now, if we gain the birth weight by day 14, we're doing reasonably acceptable from the feeding and nutrition and management. If the gaining weight does not happen until 21 days, then probably we are very poorly managing the baby. Is that clear?
Yes, clear.
Yes? Okay. No, I'm going to pause this. I don't think I want to much information. No, this is very important slide. Okay? It's very vital slide. This, days of life after birth. Okay? Now, is it day 0 or day 1? I think we've discussed that before. So we have 12 midnight is the line of starting day 1. So if the baby born at 10 p.m., then from 10 p.m. until midnight, is 0 day. If baby born at 6 p.m., then from 6 till midnight is 0 day. If the baby born at 8 a.m., then from 8 till midnight is 0 day. And day 1 start at midnight. Now, day 1 represent, and for the fluid, represent day 0 and day 1. Now, did we understand what day 0 means and day 1 means?
Sorry, dear doctor, can you repeat? Allah Zahma.
Okay. So, we are Doctor 1, Doctor 2, Doctor 3, Doctor 4, and Nurse 1, Nurse 2, Nurse 3. And then we have shifts. And we have to give same orders for the patient. And therefore, we have to use the same naming. Okay? Now we have day 1. People don't understand. People confuse between day 0 and day 1. For our unit, we'll use the following. Anything before midnight, consider day 0. Before midnight birth, consider day 0. Okay? So if the baby born at 1 a.m. until next midnight, the 23 hours, consider 0 day. If the baby born at 8 a.m., from 8 a.m. till midnight, all consider 0 day. if the baby born at 12 noon, from 12 noon to 12 midnight, first day, consider 0 day. And day 1 start from midnight. Clear? Yes or no?
Yes.
Okay, so before midnight, whatever the hours, 1 hour, 12 hours, 23 hours, 22 hours, all consider 0 day. And day 1 start from midnight. For the fluid, day 0 and day 1, day 0 and day 1, consider day 1. So for day 1, all of us, nurses and doctor, for 10 baby, will give 60 ml per kg per day. For 10 baby, how much we will give? Yes, 60, yes, day 1. How much we will give? How much we will give for 10 baby?
60.
Day 1, 60. For preterm baby, we don't give in day 1, 60. We start with 80. So 10 baby, we start 60. Second day, 80. Third day, 100. Fourth day, 120. Day 5, 135 ml per kg per day. Day 6, 150. Day 7, 165. Day 8, 180, and then 200. Do we do that for preterm baby? Yes, 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 till here. And after that, we rarely go to this level. So usually we reach 135 and we will not go further. For a preterm baby, in day 1, we start with 80. And day 2, we'll give 100. Day 3, we'll give 120. Day 5, we'll give 135. Day 6, we'll give 150. Sorry. So day 1, 80. Day 2, 100. Day 3, 120. Day 4, 135. Day 5, 150. Day 6, 165. Day 7, 180. And more than 180, we rarely go further than that unless is needed. Now, do you understand now how we give a fluid? All of us, we should write the same.
I understand, doctor, but for term babies after day 6 and day 5,
We will stay
we
same.
remain the same?
We will
Not the
not
same.
increase. Yeah, so we rarely go above that.
Okay, thank you.
And for preterm babies, we rarely go above 180 unless indicated. Now, of course, this is the standard. But now, what are the problem? If the baby is in PDA, we go less. So if it's 60, we might go 50. If it's 80, we might do it. So we decrease it when we have PDA. Clear? We also restrict ourselves when we have chronic lung disease. So this is the standard. But when we have chronic lung disease, we go less. So say, doctor, today day 3, it's a 10 baby, you should get 100. However, there is PDA, I will decrease. So it's day 3, and the baby should get 120, but there is PDA, I will go to 100. You understand? Is that clear or no?
Yes, it's clear, doctor.
Clear,
Okay.
doctor.
For asphyxia, we also restrict. So PDA, chronic lung disease, asphyxia, we restrict the fluid. And you will see how we will treat baby by cooling. For gastroschisis, before the reduction, before we cover the bowel, we have to increase the fluid. We have to give lots of fluid. So from day 1, we can give 180. When the baby have polyuria, especially in day 3 and recovery of RDS, and you come in the morning, I told you the baby 150, but you told me, doctor, the urine output is 150 ml per kg per day. So actually the baby taking 0. So in polyuria, we have also to increase. Now, is that clear how we give the fluid?
Yes, doctor, it's
For
clear,
preterm.
but
Okay.
I
So
have
it's very important that all of us write the same. Yeah, go ahead.
the word before polyuria, gastro, I don't know how to pronounce it. What does that mean?
Gastroschisis.
Mm-hmm.
Never seen gastroschisis?
Never heard on the first time.
You never heard of it. You're a doctor or a nurse?
A nurse.
Oh, you're a nurse. Doctors, have you heard about gastroschisis?
Yes, sure.
Of course,
Yeah.
director.
So gastroschisis in Winnipeg, the place where I work, because most of the girls are on drug. So we see it a lot. We see it like influenza. So each like 100 birth, we'll see one gastroschisis. Gastroschisis is opening of the bowel at the umbilicus, and the bowel goes outside, and sometimes the kidney, sometimes the liver, all goes out, the stomach, everything goes out, okay? And they are not covered by membrane. And if it's covered, same condition, but covered by membrane, it's called omphalocele. So it's a surgical problem. You find the bowel outside. And because the bowel is outside, it's not covered by skin, they start to lose fluid and get hypothermia. So the first thing we do, we bring gauze and soak it with warm and cover the bowel until the surgeon will come, and either they do one stage reduction or they put silo. It's a plastic to cover the bowel, and every day they tense the silo until the bowel goes out, and usually it takes 12 days to manage. Clear? It's a surgical problem, gastroschisis.
Okay,
Okay.
well done. Thank you. Okay,
Okay.
I get it.
Okay, there is very important point when in a sick baby, we don't keep babies fast. Okay, because when you fast, you get fasting enteropathy. Have you heard about strike, when people strike? Have you heard about people striking؟ يعني يضرب عن الطعام؟ سامعين بيه؟ واحد بالسجين سياسي يضرب عن الطعام، سامعين بيه؟
No.
سامعين بهذا الموضوع؟
لا.
ما سامعين مثلا سجين سياسي يضرب عن الطعام ما ياكل بعد؟ ما
اي
سامعين؟
سامعين
دكتور
دكتور.
سامعنا.
اي سامعين.
إيه. And that's why when they strike, they don't eat, they got fasting enteropathy. When they refeed them, they have to feed them very small amount until they got, because they will die if you feed them right away, because their stomach are fasting, their bowels are fasting. And that's the
يعني
reason we don't.
like refeeding syndrome? Refeeding
What?
syndrome? Refeeding syndrome?
No, refeeding syndrome with the IV fluid rather than the, but the fasting enteropathy, the villi, they got less. The entero lining of the and mucous membrane become thicker, and the bowel start not moving, the transition will be less. So you get fasting enteropathy. And to prevent this fasting enteropathy, we give something called MEF. Have you heard about MEF? Minimal enteral feeding. Then this is not for nutrition. So we don't calculate the calories that we get from this feed. The purpose, also, we don't calculate part of the fluid, so it's extra. We don't calculate from total fluid intake. We don't calculate from total calories. But we give it just to prime the GIT, just to keep the GIT healthy, just to prevent fasting enteropathy. They also call it trophic feeding. It's called minimal enteral feeding. Have you heard about minimal enteral feeding?
Yes, but actually we use trophic feeding other than minimal enteral feeding.
Yeah, so gut priming, trophic feeding, minimal enteral feeding, MEF, all same. So first, it's a gift. It's not considered for fluid. It's not part of fluid calculation. It's not part of nutrition. So when we calculate the calories, we don't consider the MEF. When we calculate the fluid intake of the baby from the fluid, from the infusions, we don't consider the MEF. So it's a gift. And it should not be more than 20 ml per kg per day from the TN. So let's say if I tell you, please give 1 ml every 6 hours, it's 4 ml. And the baby is half kilo. So 4 ml divided by, that will be 8 ml per kg per day. So if I tell you give 2 ml every 2 hours, that's 12. And 12 with the baby 500 grams, so 12, that's 24. So it's more than. So I cannot give 2 ml every 12 hours and consider it MEF, because it has to be less than 20 ml per kg per day. So gift, less than 20 ml per kg per day, MEF. Is that clear?
Yes, clear.
Yes, clear, doctor.
Okay, and it's not for nutrition. So we don't give it to give nutrition for the baby. And it should be human milk. Very unlikely we give formula as MEF. And it preserves the gut maturation. Okay, so these are trophic feeding. Okay. So how much we give milk? Start, we usually less than baby, we start with 10 ml per kg per day. And then we divide it every 2 hours, every 3 hours, and so on. And then we give it. And for babies less than 1 kilo, we increment 10 ml every 12 hours. And then it increases. So I will show you, I have a protocol for each age. I will show you. Wait, I will show you the protocols. Now, how we give? We give gavage feeding. What is gavage feeding? Anybody knows what is gavage feeding?
It's from NG tube, isn't it?
Yes, and feeding.
Well, it's all. No, NG feeding, all feeding are from NG. We don't have any other way to give NG until the baby starts sucking at age of 30 weeks. So any feeding, anything through the mouth should be in the feeding tube, because before that, the baby cannot feed. So no, gavage feeding does not mean NG feeding. Yes, we use the NG to give gavage, but gavage feeding does not mean NG or OG feeding. Anybody know what's gavage feeding?
Dear doctor, I think it's by gravity.
Yes. So we use the column of the milk. So you put the milk in a syringe. So the syringe have a body and the plunger. We take the plunger out. We keep the body of the syringe. We fill it with milk, and we connect that syringe to a feeding tube. And then we allow the milk to go by gravity. And then we can move it faster and slower by moving up and down the level of the syringe. So if the feeding is very fast, we bring it down. If the feeding is very slow, we take it up. So we move up and down to move the fluid, and we should never give more than 1 ml per minute. Okay, and I will tell you how. So gavage feeding using gravity.
Doctor, it is just yani by normal syringe, or
Yeah,
special
syringe.
syringe.
It can be special, it can be normal. It doesn't matter. But it should be big enough, and then you remove the plunger. هاي الكباسة تشيليها تخلين بس البدي وتمليه
يعني
حليب.
not by 5 cc, it must be bigger, not by 5
Sorry,
cc
again?
syringe. It should be bigger than 5 cc syringe, maybe 10 cc, 15 cc, like this.
Well, 10 will not move. The milk will not move. You will not have column. I don't think you will have column. So you need at least 10 or maybe 20, maybe 50. I don't know. It depends on the volume. Okay.
Okay.
And remember, if the milk is not moving until 20 minutes, then you need to move faster. So you should not give gavage more than 20 minutes. And it should not be very fast. It should not be less than 1 ml per minute. So we cannot give like 2 ml per minute. It has also to be slow. So if you have 10 ml, you cannot give it less than 10 minutes. Okay, but you cannot exceed. So if you have 25 ml, you have to give it in 25 minutes, in 20 minutes. If you have 20 ml, you have to give it in 20 minutes. If you have 19, you give it in 19 minutes. If you have 10, you give it in 10 minutes. But if you have 9, you give it in 10 minutes. You cannot give it less than 10, but not more than 20. Clear?
Yes.
So change the syringe, level the syringe up and down until you get appropriate timing. Okay, and you should not give more than 2 ml per minute. Okay, and gavage feeding can be scheduled feeding. So I tell you, give gavage feeding 20 ml every 2 hours, or I tell you every 3 hours, or every 4 hours, depending on the age. Okay, so usually if you're a preterm, we give every 2 hours. If you are term, near term, we give every 3 hours. But if you're term, we can give every 4 hours. Why we change? Because this cannot tolerate. Why we give every 4, not everybody at 2? Because we will exhaust the nurses. Okay, is that clear what the meaning of schedule feeding? Okay, so we have gavage feeding. Okay, this gavage feeding called also bolus feed. So bolus feed by gavage. But also we can give bolus feed by infusion pump. So you bring the milk, put it in infusion pump, and tell the infusion pump, give the milk over 20 minutes. So that we can infuse it. Okay? Okay, so that's not gavage. Okay, that's why we don't call it this. Gavage is by gravity. And the reason why, do you know why we give gavage not by infusion pump? Anybody knows? Because of the perception pressure. Okay, so the stomach has ability to expand to get the food. And if you give more than that, you might cause perforation or bleeding. Okay, because the stomach has the ability to expand to receive the milk. And that's the reason why we use gavage, because in gavage, the gravity cannot force the milk in the stomach that's not distendable. While infusion pump, it will. Okay, at most of the time, we use gavage, or sometimes we use infusion milk. Okay, so that is called bolus feed. Now there is intermittent continuous feeding. Remember, bolus feed over how long? Bolus feed over how long?
20 minutes.
20 minutes. So anything over more than 20 minutes, but it's not continuous, it's called intermittent continuous. Okay, so it's more than 20 minutes, but less than continuous, called intermittent continuous feeding. Okay, continuous means all the time the baby is on milk. Okay, and when we use intermittent continuous feed, we use infusion syringe. Okay, and then continuous feed all the time. Clear? Between gavage, bolus feed, intermittent continuous feed, and continuous feed. Any question? Okay. So how we calculate the fluid? We have two methods, two assumptions. Okay. So these are assumptions that we need to, so I'm going to pass it. So the first method of calculating the need of fluid, first 10 ml, 10 kilo, we give 4 ml per kg per hour. Second 10 to 20, we give 40 ml per hour for the first 10 kg, and 2 ml per kg per hour for any increment more than 10 kilogram. So if the baby is 12, then it's 40 ml per hour. And then we have 10 ml for each kilogram, and the baby is 12, so we have 2, and that means 4. So this baby, if 12, will get 44 ml per hour. If the baby more than 10 kilo, so we'll give 60 for the first 20, then 1 ml per kg per hour for anything above 20. Maximum, we don't reach more than 100 ml per hour. We never give, and we don't give more than 2400 ml per daily. Clear in method 1? This is the maintenance fluid. Is it clear?
Yes, clear.
Yes. Okay, method 2, we don't use per hour, we use per day. So first 10, 100 ml, second 10, 100 ml plus 50 for each kg, and more than 20, 1500 ml, and 20 ml per kg for any more than 20. Okay. So if we do it in both methods in one baby, we will find the hourly format will be a little bit lower than the daily format. There is a little bit of difference, okay? But these are differences are not significant. Electrolyte, the most important is sodium, chloride, and potassium. And I'm not going to go to details because usually sodium we give, 2 to 4, 2 to 6, and we go up and down milliequivalent per kg per day. And potassium, usually we give 1 to 2 milliequivalent per kg per day. So I don't want to go for details of this and confuse you. So I'm going to pass all these. Now, we always need to give dextrose. And it's considered that 5 to 10% dextrose solution is very safe. At the newborn babies, we start with D10, and then later on we use D5. Now, change in water loss, you have prematurity, if you have burn, if you have fever, if you mechanically ventilate, if you have gastrointestinal problem, if you have oliguria, if you're sweating, all can change the water loss. Okay, so I don't want to go to details of this, but these are the fluid that we give. We give D5W, D5 dextrose water. We give D10W, we give normal saline, and it's usually 0.9. Okay, and how much the potassium concentration in 1 liter is? How much? How much? How many milliequivalent of sodium in 1 liter in normal saline? How
As you
much
directly
sodium? 154
100.
milliequivalent, right?
77. 154.
Yeah, so 154 in 1 liter, and it's 0.154 in 1 ml. And it's 77 in half saline in 1 liter, and it's 0.077 in 1 ml. And in one quarter of normal saline, it gives you 34 milliequivalent of sodium in 1 liter, or 0.034 in 1 ml. Now 3% normal saline, you just need to multiply it. So 154, that's the normal saline, which is 3 divided by 0.9, you will get 3.3. So 3.3 times 154, you get 513 milliequivalent in 1 liter, and you get 0.5 milliequivalent in 1 ml of normal saline. So that's usually we calculate when we give oral sodium. So I will tell you, let's say I want 3 milliequivalent of sodium per kg per day, and the baby is 2 kilo. So we need 6 per kg per day, and we'll give it 4 times. Okay, so 6 divided by 4, that will be 1.5. So if we want to give it as a 3%, 1.5, each 1 ml have 1.5. So 1.5, how many ml will give? Do you want to calculate? Guys, talk to me. You need to talk to me to understand. If you keep silent, you will not understand. Hello? Are you there? Hello, do you hear me? Hello? Hello?
Yes, doctor, we are understanding, but we are not calculating.
Well, you need to calculate. Very important. So
Yes,
again,
yes,
so let's say we need to give, I told you that this baby is 2 kilograms, and I will give 3 milliequivalent per kg per day of sodium. So the weight is 2 kilograms, and we give 3. So 3 times 2, how much? 3
6.
times 2, 6. Okay, and I will tell you, I will give it over 4 doses. So 6 divided by 4. 1.5. Okay. Each 1 ml of 3% contain 0.5 milliequivalent. and I want 0.5. So each 1 ml contain 0.5. So I will give 3 ml of 3% normal saline 4 times. That's mean total 12 ml to get me 6 millimole per day. However, if I want to give from normal saline, it will have more water. So if I am fluid restricted, I will give this. But if I am not fluid restricted, I will give this. So how I calculate? I need 6 millimole, right? So 6 divided by 0.154, you get 38 ml, 0.9, 39 ml. And 39 divided by 4. So you need 9.5 ml every 6 hours to get 6 millimole of sodium chloride if you want to use the normal saline. Do you understand?
Yes.
Okay, so that's how we calculate. Oral rehydration solution, flavored, or you prepare it by yourself. I'm going to pass this. I don't think it's important. Outpatient, you can use oral rehydration solution. So I think you know that. I'm going to pass this. Outpatient, mild, fluid is recommended, feeding is recommended. What is ALD? Anybody knows what's ALD? Ad lib demand. So the baby will take whatever they want. Ad lib demand. So in English, ad libbing mean talking to yourself. So you're alone and say, oh, باكر أنا راح أسوي هيجي وراح أسوي هيجي وراح أطلع وبعدين تشوي نفسك. You're ad libbing. You're talking what's in your brain. So you're doing whatever you want whenever you want. Ad libbing. So ALD is ad lib demand. So the baby can take whatever they want. Okay. So these are calculation. I don't think if there is vomiting, it's recommended by CDC to give ondansetron to prevent vomiting. And then this is the dose, how to give the ondansetron, depending on these are the references. I don't think this is important. IV fluid, if you are shocked, if you have abnormal mental status, if you have persistent vomiting, if you have bloody diarrhea, if you have ileus, abnormal electrolyte, if you have glucose problem, you need IV fluid. Okay, in shock, you give bolus. This is very simple, but we will have like shock session and we'll talk about it. But usually we give boluses and then we calculate the fluid and then we subtract the boluses from it. Holiday cigar method, the one we did, first 10 kg, we give per day 100 ml, per kg per hour 4 ml. Second 10 kilo, we give 50 ml per kg per day and 2 ml per kg per hour. And anything more than 20, we give 1 ml. And this is how we calculate. Maintenance electrolyte, sodium usually more than potassium. I'm not going to give you these numbers. I don't think it's important. Calculation of this deficit, the percentage of dehydration times the weight times 100, you get the deficiency, and then you take the bolus and then calculate. So I'm going to pass these. I don't think these are important. Isotonic. I don't think these are important. Okay. So I'm going to pass these. Isotonic, you get the same. We can use half saline, normal saline. Okay. Hypotonic. I think dehydration, you guys know how to deal with it. I'm going to pass it. Hypernatremic, you guys know that it's longer. Feeding protocol, I will give you a copy how to feed each baby. This is feeding protocol for 500. We will have specific session on the feeding, and this is how we feed a baby 500 to 600. And then this is another feeding protocol, 600 to 700. And this is 700 to 800. And this is 800 to 1 kilo. And this is 1 kilo to 1250. And this is 1250 to 1.5. And this is 1.5, 1250 to 1.5. And this is how to feed infant of diabetic mother. I will have a session on infant of diabetic mother, so I will pass this. And a scenario, we'll discuss it in the morning. Okay? So today I'm just going to give you a glimpse of, okay? And I will meet you tomorrow morning. Okay?
Okay, thank you,
تمام
Doctor.
دكتور إن شاء الله.
Thank you very much. Thank you. Bye-bye.
Thank you, Doctor. Thank you.
Thank you.